Good morning. Welcome to Chapter 4 of Language of ERCP module in Ramaya Memorial Hospitals, Department of Gastroenterology. So this deals with cholangiography. How are you going to interpret the different cholangiograms? How are you going to stent? So we have covered disinfection, sphincterotomy, balloon, as well as the guide wires, baskets. So we are going to look at how are you going to interpret the cholangiogram, as well as what are the different types of stents that we are going to use. So cholangiography is basically like we are going to use a full strength contrast, and we switch to dilute construct when stones are suspected. So we always fill the proximal common hepatic duct as well as a common bile duct first, and move the sphincterotom slowly down, and then we fill the entire bile duct. If a part of the bile duct is not filled, we can change the patient position or we can change the scope position. When the patient is in prone position, like left hepatic duct fills first, as it is the most dependent position in prone position. So what is the contrast used? Predominantly we tend to use iodine based water soluble contrast, either hypotonic or isotonic. So predominantly we tend to delineate the bile duct, what is the duct diameter, what is the stone diameter. Two different concentrations are used. One is 300 to 350 milligram of iodine per ml, so which is dense, which is initially used. It is better for delineating intrahepatic biliary radicals, as well as for doing an occlusion cholangiogram, as well as contrast based cannulation is much more because it is much more dense as viscous, like it causes less chance of post ERC pancreatitis. Less dense, that is 150 milligram per ml dilution we tend to use, like whenever we identify that it is a stone, that is a possible pathology. But the problem with the less dense is it can obscure small stones, and rarely this, because it is iodine based contrast, there can be chance of reactions. Occlusion cholangiogram always reveals small stones, like before we ensure that the stent are we going to place or not going to place, we should always do an occlusion cholangiogram such that we are doubly sure that there are no stones which are there within the bile duct. How are you going to do an occlusion cholangiogram? We are going to pull the balloon slowly till the distal end of the bile duct. We are going to inflate the balloon, and then we are going to inject contrast and delineate the complete bile duct with right hepatic, left hepatic, as well as the intrahepatic radicals. So like after that, like once we ensure that there is no stones, like deflate the balloon, take the balloon catheter up to the hilum, and then inject saline or the water, such that the contrast, viscous contrast and all will come out clean, and such that the post ERC cholangitis is much less likely. GB might get filled when you are doing occlusion cholangiogram. At that time it may show small stones, but nothing to worry, will not be able to take the contrast out from the gallbladder. Which patient position is much better? So some people will say prone, some people will say supine. It is all operator choice, but majority of us are being trained in prone position, because that will bring the duodenum closer to the scope. Second thing is, like AP diameter is much more shorter than the lateral diameter. So in contrast to the lateral, either prone or supine is better. Supine anesthetist will be much more happier, because in case there is a desaturation or something, he will be able to intubate faster. Prone, like endoscopist, will be much better, so because it gives a better endoscopic stability. So which side is up? So in a prone position, right of the patient gives the right of the image. So always do a scout image first, because that is going to record, like if at all there are any calcifications of coastal cartilages or stones which are radiopaque, such that we are not taken aback after we inject contrast or after we do endotherapy. Magnification always matters, like we need not be too much concerned whether it is a zoomed image or not zoomed image. We compare with the objects which are there on the fluoroscopy. So we tend to look at the scope diameter. So what is the scope diameter? Scope will be like 1.1, 1.2 centimeter. In contrast to the scope diameter, how much is the length of the stricture? Like two scopes image, we tend to say that it is around 3 centimeter is the stricture size, and then take it from there. So can it happen that the stone is noted on the imaging, but there is no stone on the cholangiography? It can happen, because stones can pass spontaneously, and if on cholangiography there are no stones, it is always better to avoid sphincterotomy rather than do a mini sphincterotomy or something like that. Whenever the right hand assistant is injecting contrast, you please ask the right hand assistant, ensure that there should not be any balloons, because the most important thing is when you inject balloons, it can masquerade like stones within the bile duct. Second thing is, you should always flush the sphincterotom, because when you flush the sphincterotom, you are not having a dead space volume, because each catheter has got a dead space volume. So if it is a 1 meter long accessory, the dead space volume can amount to 2 to 3 ml of air. So suppose we inject contrast, there can be a chance of that much amount of air can form a bubble, and that we can think that it might be a stone. In a conventional cholangiographic picture, what we are going to say is two right anterior segments will come and join into RASD, that is right anterior sectoral duct. Two right posterior segments will come and join and then form a right posterior sectoral duct. RASD and RPSD will form right hepatic duct. Left side 2, 3, 4 segments will form the left hepatic duct, and the caudate lobe can drain either into the right or into the left. Right hepatic duct and left hepatic duct fuse to form common hepatic duct, and once the cystic duct joins, it forms a common bile duct. This is an usual anatomy in 75% of the time. The most common culprit is the right posterior sectoral duct, which can join either into the confluence or into the left hepatic duct or at the cystic duct confluence. So RPSD, we should be able to ensure like where exactly it is joining for cholangiography interpretation on ERCP. For surgeons, they are most often concerned with where is the cystic duct insertion, because this is very important whenever we are placing a stent. There are some reports, if you place a covered metallic stent occluding the cystic duct orifice, there is some chance of post stent cholecystitis that can happen. 15% of the time, right posterior sectoral duct can enter into the left hepatic duct. At that time, it is always better you place your stent like into the left system, because you are draining 2, 3, 4 as well as the right posterior sectorals, like that is 7 and 8 you are draining. So like you are draining almost 5 segments. In contrast, if you place the stent towards the right system, then you are draining only 5 and 6. So that means you are draining only 2 segments of the liver, in contrast to 5 when you place a stent into the left system, especially when the RPSD is joining into the left lobe. Caudate lobe, like it is little atypical, it derives blood both from the right as well as left hepatic arteries. It drains directly into the IVC. It drains bile both into the RHD and as well as the left hepatic duct. What is the personal protection? Like we should always use red gowns. Like how much gown should be worn? Like it should cover all the red marrow areas, that is the spine, shoulder, pelvis, femoral bones. And whenever important, especially when the fluoro is on, we should always turn towards the patient, because majority of the lead aprons are open on the sides. They are not like vest and gown types, they are like complete gowns. So majority of, if you see on the side, they are open. So whenever the fluoro you are telling on, you turn towards the patient side. So because that is where the fluoro rays are coming. Thyroid shield should be on, and we should always keep the fluoroscopy time very short. Pregnant women, like the CBT cannulation can be assessed by aspiration of the bile through the sphincterotomy. We can always use an ultrasound machine by noting the guide wire entering into the bile duct. We can always use the skirt of the 2-piece lead apron as a protective shield for the fetus. Most important thing is interpreting the cholangiogram, because that is where the trick lies. Because when you don't interpret the cholangiogram much better, so the chance of endotherapy will be much difficult. So like once you do cholangiogram, then whether we are going to stent the right system or the left system. So single stent is good enough for drainage, either the right or the left. But the most important thing is the right system branches 1 centimeter beyond the hilum, whereas the left system branches 2 centimeter beyond. So given a choice, left system might drain 2 segments more, but whenever the growth involves the type 1 type bismuth type, but it all preferred where the guide wire has entered, like how much difficult is there for the endoscopist. Like whenever there is a preferred stent placement, like we think about placing multiple stents, we always place the left side first, which has got more difficult anatomy as well as a difficult access to enter into the left system. Whenever there is a multiple stents we are placing, like always place the longest possible stent. Like we determine the stent size by looking at the length of this bile duct, by looking at the, like we can mark and then we can pull the sphincterotomy. That will give the approximate size of the stent that we can use, or we can use the scope diameter and then we look at the size of the stents that we are going to use. So the longest stent we are going to place first. The second stent, always ensure that the first stent is not going in. So that is very important, because whenever we are inserting the second stent, it might drag the first stent inside the into the bile duct. So the stents, whenever we say, like, we classify them whether they are straight stents or pigtail stents. Whenever we say straight stent, these are all Amsterdam stents or Cotter-Lewin stents. These vary in length. The length is in between the two anchoring flanges, because Amsterdam stent is open at both ends, as well as on the sides there are flanges which are going to secure the Amsterdam stent in position. Like, they are called as straight stents, but they are not straight. They are little angled in the middle. That angle as well as flanges will maintain the stent in position. How are you going to deploy the stent? It is by one action stent introduction system, that is called as Oasis, like, which goes over the O35 guide wire, which is placed within the duct of choice. And then Oasis is around 480 centimeters. It has got a 6 French guiding catheter with a taper tip for cannulation. It has got radiopaque markers for 7 centimeters apart for accurate positioning of the stent. There is an outer 10 French Teflon push-on tube that is useful for pushing the stent over the 6 French guiding catheter, which is there inside. Once we identify a suitable length of the stent that needs to be placed, we should ensure that the proximal end of the stent or the proximal flap is 1 centimeter beyond the stricture. So that is the level of obstruction, such that it aids in drainage position. The difference between Amsterdam and the pigtail is, the pigtail is curled at the tip. Like, if at all there is a dilated system, the chance of migration of the Amsterdam stent is much more. Whereas in the pigtail, because it is curled at the tip, we are going to hook it to the one of the right hepatic duct or in the left hepatic duct. So, like, there is no stricture, the dilated system is there. So in pigtail, there are multiple small holes that are there on the side as well as at the tip. So that aids in drainage of the bile. Single pigtail stents we tend to use in pancreatic endotherapy. So in this, we are using only a pusher tube, like appropriate size of pusher tube. We are placing a 10 French double pigtail stent. We use a 10 French pusher tube to push the stent across over the guide wire into the respective duct. Whereas in a straight stent, we use Oasis. There is a good flow. It can be easily migrated. It is used in stricture scenario. It is used for pancreatic endotherapy as well. But here we need to use Oasis for deployment. We can use double Amsterdam stents for adequate drainage, and the stent length should be approximately 1 stent below the stricture. Once we place a stent, pruritus disappears within a day or 2 days. Serum bilirubin starts declining 2 to 3 milligram per deciliter per day and may return to normal in around 2 to 3 weeks time. Slow recovery might be because of prolonged obstruction as well as incomplete drainage because of a poor stent location. So whenever we look at a malignant biliary obstruction, like, rather than doing multiple ERCs, we can straight away place a biliary self-expanding metallic stent. So these are Premalium covered metallic stents, which with a 8 French delivery system. So it is covered, it can be partly covered, fully covered metallic stents. Like, partly covered are much better because the distal uncovered portions will aid in fixation of the stent. Like, distal 2 millimeter might not be covered. Uncovered is for palliating. Uncovered stents can be used for palliating obstructed biliary pathologies, because that is going to reduce the chance of migration, as well as if at all the stent gets clogged, we can always do an endotherapy by using plastic stent, or you can place one more metallic stent through the earlier placed metallic stent. It has got excellent endoscopic as well as fluoroscopic visualization because of a reconstructability. So covered SEMS, the advantage is it has got a longer duration of patency. So, but the only disadvantage is it has got greater chance of stent migration. So as well as tumor overgrowth from the tip, the tumor overgrowth can happen. Whereas uncovered SEMS, like the tumor ingrowth can happen within the stent in malignant biliary obstruction. So we should ensure that the cystic duct orifice is not being covered by the stent, because otherwise there can be chance of post-SEMS deployment cholecystitis. Contraindications, especially in a perforated bile duct, there is a small intrahepatic biliary radicals, like where we are not able to pass the stent across. Strictures that cannot be dilated to the extent that the 8 French delivery system is not going to go in. So at that time we are not supposed to open the stents across. Whenever we are using a biliary brush, that is for stricture, so we should understand that the tip of the brush is around 1.5 to 3.5 centimeter, that is the tip, and it has got around 2.5 centimeter of brush. So it is around 100 or 150 to 200 centimeters length. So we are going to pass the brush across over the guide wire. We place the tip till the tip of the stricture, and then the right hand assistant is going to push the brush across, and to and fro motion can be 5 or 10 times, and then the brush is removed completely from the accessory port, and a slide is made and sent for histopathology, for brush cytology, for looking for determining what is the stricture due to. So once we do a brush cytology, then we are going to place either an Amsterdam stent or a metallic stent depending upon the etiology. So this completes the module of language of ERCP chapter 4. Thank you.